Hi everyone. So this is the second episode of the Nitrosamine series, and in this episode we are going to learn the six very important topic. The first one is the mitigation strategies of the nitrosamine that is being followed across the globe, across the regulatory agencies, followed by the AI limit or acceptable intake limit. Then we'll learn the establishment of the EI, that means how these acceptable intake limit for the nitrosamines they are being calculated, then followed by the analytical methods for it, what are the regulatory guidance for it, then the regulatory requirements for the testing, and finally we'll learn about the number of batches that is being taken for the confirmatory testing. So let's start one by one. So first thing that we are going to learn, that is the mitigation of nitrosamines. So there is this three steps which is being followed. The first one is risk assessment, then confirmatory testing, and the control strategy. So these are the three-step process which is being followed across the globe. For example, whether it is FDA or EMA or Health Canada or Anvisa, you name it, all the regulatory agencies, they have this three steps process. So the first one, the process is the risk assessment. So risk assessment means this is basically a theoretical risk assessment, and it has to be done by all the stakeholders of that particular drug product. For example, if there is a drug product, there will be API vendor, there will be excipient vendor, there will be FP manufacturer. So API vendor will do the risk assessment for their API. Excipients manufacturer, excipient vendor will do the risk assessment for their excipients, and the FP manufacturer will do the risk assessment for the FP. And all this risk assessment will be finally combined together, and there will be a single one document for the risk assessment of the final drug product. Now this is how this risk assessment is being done. So in my first video I have explained the root causes of the formation of this nitrosamine. So these vendors, the API vendor or excipient vendor or the FP manufacturer, they will try to identify that the causes of the root cause, whether they are being present for that particular drug product or not. So this is just a theoretical risk assessment. Okay, and on the as a result of the risk assessment, they are going to categorize the risk whether it is low or high. And the regulatory requirement is that you have to, as a FP manufacturer, you have to conduct this risk assessment studies, but there is no need to submit this document, but you have to conduct it. And whenever the agencies they ask for it, as a pharmaceutical company or as a finished product manufacturer, you have to submit this document to the agency. Okay, so this is the risk assessment. Now the very important thing here to note is that if after the risk assessment, if it is found that there is no risk which is associated with this product, then there is no need to go for the step 2, that is the confirmatory testing, or there is no need to go for step 3, that is the control strategy. Okay, so risk assessment, that is why it becomes a very important step. Now suppose after the risk assessment you find out as a FP manufacturer that yes, there is some risk of formation of nitrosamine. Now we don't know whether it is going to form or not. This is just an analysis, theoretical analysis, based on which we are predicting that yes, there is a chance that nitrosamine may come into my final product. In that case, you have to do testing of that product, that is known as confirmatory testing. So this testing is being done by the appropriate methods. So there are multiple methods which are being given by the regulatory agencies, and you can try those methods and check whether this is working out for you or not, or you can also develop your analytical method, and with the help of that you have to do this testing. And suppose if it is found out that yes, there is presence of nitrosamine and it is above the acceptable intake limit, in that case you have to show the control strategy. That means you have to tell it to the regulatory agencies that what are the control steps that you are being taken, or you have to take to reduce the nitrosamine or to prevent the formation of nitrosamine. So this is the about the mitigation strategies of nitrosamine, and this is the three-step process which is being followed across the globe. I hope you understand this point. Now we are going to learn about the EI limit or acceptable intake limit. So let's dive deep into it. So if I see the EI limit, the definition you can see on the screen, that an EI limit is a daily exposure to a compound such as nitrosamine that approximates a 1 in 1 lakh cancer risk after 70 years of exposure. In simple language, This is the amount of nitrosamine which if you give to a population of around 1 lakh patients for 70 years, then after the 70 years only one out of that 1 lakh population is going to have cancer. So this is that amount. So this is a very safe amount, and that is why it is also known as the acceptable intake limit. Now you can see a list on the screen of nitrosamine and their EI limit, and this limit has been given by the FDA for the 7 nitrosamines which are identified in the drug product since 2018. And the limit, if you look into the EI limits, it is given in terms of nanogram per day. For example, 96 nanogram or 26.5 nanogram, mostly 26.5 nanogram is given, and it is nanogram per day. That means the level amount, it is very very low. Okay, and if you are confused about which is the most potent here, the one which is having the lowest AI limit is the most potent nitrosamine, because a very low amount can cause cancer, right? So it is very very potent. Now the EI limit is given in terms of nanogram per day. Now if you are going to control these nitrosamines in your analytical methods through in terms of specification, then in specification limits are not given in terms of nanogram per day. It is being given in terms of concentration terms, for example ppm. Okay, so in that case the EI limit which is given in terms of nanogram per day, it has to be converted into a ppm value. So the conversion formula is that ppm is equal to AI divided by the MDD, that means the maximum daily dose. So whatever is your AI limit, if you divide it by the maximum daily dose, then you will get the term in terms of ppm. Now the maximum daily dose you can find on the product label. Okay, now the thing that you have to keep in mind, the list which is given here, it is for considering the fact that there is only one nitrosamine present. So it is the limit, it is given a compound specific limit. For example, for NDM it is 96, for NDA it is 26.5. So it is compound specific limit considering the fact that there is only one nitrosamine present. But in case your product have more than one nitrosamine, in that case the approach will be different. So the approach here, the approach will be the total limit, it should not cross the most potent nitrosamine. For example, the first, let's consider the first three here: NDMA, NDEA and NMBA. Now suppose your product has only NDMA, then what will be the AI limit? 96. But if your product has three: NDMA, NDA and NMBA, then the AI limit won't be 96, it will be 26.5. So all the three, it should not cross 26.5. So it is become more and more stringent because there are presence of more nitrosamine, so the risk is more. That is why the limit has to be more stringent here. Now there are two ways of calculating it. For example, fixed approach and the flexible approach. Now this video is not sufficient to cover the fixed approach and the flexible approach, because those are very big, and if I am going to cover those two topics here, it will be a very big topic. But as of now, uh, the both of whether if you are going for fixed approach or the flexible approach, the main ultimate target is same, that the total daily intake of the all the identified nitrosamine, it should not exceed the EI of the most potent nitrosamine. So it is about the EI limit. Now let's look at the establishments of this EI, or in short, how these EI limits are being calculated, or how FDA has calculated the limits for those impurities which you are seeing on the screen. So there is just two approach which are being followed here. One, uh, these values are calculated on the basis of the rodent carcinogenicity data, or the TD50 values. Okay, what is TD50 values and how calculated? We're going to learn it in just a few moments, and then followed by, if there is no substance specific data available, then how you are going to approach it. So let's first understand the first one, then how from a TD50 value this limit is being calculated. So TD50 is basically nothing but a dose or amount of dose which if you are giving to a patient or population, 50% of that population will die. So that is a TD50 value. So now if I draw a curve So there will be x-axis and y-axis, and if in the x-axis if I put cancer occurrence, okay, and in the y-axis if I put the dose here, and then somewhere in between the TD50 value, suppose it is here, and now if you, sorry for my bad drawing here, so now suppose this is your TD50 value, okay, and this is the dose, and this is the cancer occurrence. That means at this particular dose, so this will be a TD50 dose. At this particular dose, around 50% of the population will die. So suppose if there are 1 lakh uh, population is there, okay, so at this particular dose almost 50,000, okay, will die. So this is a TD50 value. So once you got that value, TD50 value, scientifically with the statistical help, this value is being extrapolated downwards, and it is being downwards towards certain value where only one will get cancer out of 1 lakh, okay, and that's in this point the particular value it becomes your AI value. So this is how this EI limit is being calculated. Now I hope you understand how to calculate this EI limit from the TD50 value, right? So now there is this database which is also known as the carcinogenic potency database or CPDB database, or LASA carcinogenicity database, LCDB database. Now this is a database which is having a TD50 value for about 140 nitrosamines. Now you might be wondering that if this database is having 140 nitrosamines, then why FDA has listed only 7 nitrosamines in their guidelines? The reason being the fact that those 7 nitrosamines are the one which are being mostly present in the drug product. Now in my first video I have already explained that nitrosamine is not only present on the drug product, it is present everywhere in the environment, whether it is water, whether it is food product. So this database, they have nitrosamines for all the kinds of sources, but FDA listed the ones which are being present in the drug products. Okay, now suppose um, uh, you have found a nitrosamine which is new, and for this there is no database. You have checked the database, you did not find that nitrosamine, so there is no carcinogenicity data available. Then in that case, what will be your approach for setting up the I limit? Let's look into that one. So there are these 4 guideline which is given by the industry for it. So the first approach that you have to take, that is the CPC approach or carcinogenic potency categorization approach. So this is approach which is given in this industry, and it is very latest in the industry because the guideline for the guideline by FDA for CPC approach was given by August 2023, and for from EMA it was given in July 2023. So it is very latest in the industry, and I'm going to cover this detail in my next video because this is a topic which needs a dedicated proper video. But as of now, you should know the first approach that you should take when there is no carcinogenicity data, that is the CPC approach, followed by the second approach that you can check, that is the EMS test. Okay, so in this test, if there is a negative result, then the nitrosamine you can set a EI limit of 1.5 μg per day. But if this test is having a positive result, then you have to go for CPC approach or the option 3. So the option 3 is that you have to find a structure which is very closely related with your nitrosamine, and that structure is having a carcinogenicity data. So whatever the differences in the structure, that you are going to compensate with the help of SAR or structure activity relationship concept. It is basically done with the help of software. So this is being calculated. So this is the third approach. And the fourth approach is you have to conduct a mutagenesis study, and you have to show that your nitrosamine is non-mutagenic. In that case, if it is non-mutagenic, then you can control by the limit of ICS Q3A or Q3B. Now the Q3A and Q3B are guideline which is given for normal impurities, okay, which are non-mutagenic impurities. Okay, but the chances are very rare that your nitrosamine will be non-mutagenic, because it is nitrosamines, they are very potent by its nature. So if the mutagenesis study fails, then you have to go for option 1 or option 3. That means either you have to go for CPC approach, or you have to go for the structure activity relationship approach, right? So now I hope it is clear for you. Now we are going to see the analytical methods for it. So there is a list of methods which is being given by all the regulatory agencies across the world, which are being developed till now, and the list you can find on the description. So in the description I have given I have mentioned the list of methods which are identified by the FDA, EMA, Taiwan, Health Canada, and Visa. All you can get on the description. Please go and check the list of methods if you are interested, and if you are from analytical lab, you can go and use those methods. And suppose while using those methods you find out that those methods are not sufficient for a drug product, and you need to develop a method altogether. Then in that case, suppose you are developing a method, so in that case you need a standard, right? And while developing this method, you understand that this developing the standard itself is very difficult. So in those cases, the agency considered that as the developing the standard itself is very difficult, so the chances of forming of those nitrosamines is very rare. Okay, so there is no need to do confirmatory test. But again, this is kind of approach where you need to justify with lots of literature data or the studies, that is R&Ds that you have done to develop that nitrosamine or standard, but you have failed. So all those data that you have to submit to the agencies to justify that it is not possible to develop the standard. Okay, so this is the regulatory approach for it. And suppose if there are the same analytical method you are going to use for multiple nitrosamine, in that case the LOD of that particular method, it has to be demonstrated for each of the nitrosamines. Okay, so LOD, if you do not know what is LOD, which is also known as the limit of quantification, it is basically a validation parameter for any analytical method, which says that it is the lowest amount of any compound which the method can quantify. Okay, so that is LOD. So now if you see at the regulatory requirement for testing, now there are these three ways. One is routine testing, third was skip testing, and followed by the omission of testing. So routine testing means you are being testing the nitrosamine in all the batches routinely. Skip means you are not doing on all the batches, you are skipping one or two batch and then you are testing. So it is an interval testing. And the finally omission testing, that means you are not doing the test at all. So there is separate guidelines for this kind of testing. So first, routine testing, FDA says that if the nitrosamine is above the LOQ, then you have to do routine testing, and FDA says the LOQ has to be at or below 0.03 ppm. So if your nitrosamine is present at 0.03 ppm or more than 0.03 ppm, then you have to conduct the testing on a regular basis. But FDA did not given any guidance for the skip testing, and also did not given any guidance for the omission testing, but EMA has given such guideline. So for EMA, the routine testing has to be done when the content is more than 30% of the EI. So EMA has given the guidance in terms of EI. So whatever the EI that you have given, you have to first convert into a ppm, and if the nitrosamine is found out 30%, more than 30% of that particular EI limit or the ppm limit, then you have to conduct this testing on a routine basis, right? And suppose if you are doing skip testing, then if the content is found below 30% of the EI limit, then you can go for skip testing. Now for the skip testing, you have to keep in mind that LOQ of that analytical method, it also should be at 30%, right? Because to determine that your impurity is at 30%, your method also should be capable enough, should be detect that amount at that lower amount. So the LOQ has to be more and more lower, right? So if you see in case of routine testing, the LOQ, it should be EI limit. For let's take example, the EI limit, suppose it is 30 ppm. So if you're doing for routine testing, the LOQ also should be 30 ppm. But if you're going for skip testing, then whatever the 30% of that 30 ppm, your LOQ also should be at that level. So it is more and more stringent. Now, if I talk about the omission of testing where the content is 10% of the EI, then in that case you can remove it from your specification. There is no need for testing. So what EMA considered that if the amount of this nitrosamine, if it is less than 10% of the EI, that means it is negligible, it is not present. But here the condition is that the LOQ of your analytical method, it should also be at 10% level. So the LOQ is far more lower, so it is more stringent, right? Now, if I talk about the Health Canada, in case of routine testing, the EI limit is, if it is more, the content is more than 30% of the EI, you have to go for routine testing. In case of skip testing, there is no guidance given, and in case of omission testing, yes, if the content is less than 10% of the EI limit, then you can go for omission testing. Now, regarding the other agencies, for example, Anvisa or Taiwan, okay, so mostly the other agencies, they do follow the FDA guideline or EMA guideline, okay. So these are the guidelines overall. Now, let's look at the number of batches that the regulatory requirement is in case of confirmatory testing. So the regulatory requirement is 10% of the annual batches, or the 3 annual batches you have to test, and if there is less than 3 batches which are manufactured annually, then it has to be tested for all the batches. Okay, and that test, not only you have to do this test for the new batches, also you have to do for this testing for the batches which are in the stability, that means the old batches. Okay, and suppose um, there are multiple strength for a same doses, then there is no need to conduct all the strength. Okay, you can justify, you can use the bracketing strategy, and you can do for, suppose if there is 3 strength of same doses form, you can do for 2, and you can use the bracketing approach, and that you have to justify to the agencies. Okay, so this is all about this. So we have learned these 6 topics today, starting from the mitigation strategies, then the AI limits, then how these AI limits they are being calculated, followed by the analytical methods and their guideline, then what are the regulatory requirements for this testing, and followed by the confirmatory testing on the number of batches that you have to take. So this is all about the second part of this video. In the next part, I am going to cover the CPC approach and the NDS rise, which are also a very new topic in this industry. I hope you like this video till now, and if you find out that you will learn something new, please do subscribe, uh, like this video, share with your colleagues. See you on the next one.